Thank you, Denise. Vitamin D is a particularly complex area that needs a lot more research. And now we have Dr. Irv Rosenberg, who's going to speak to us about B vitamins, omega-3, and brain health. And as you all know, he's from Tufts University.
Well, I'd like to start by congratulating the AARP Foundation for taking interest and involvement in what is obviously an extremely important aspect of our general approach to aging. I also thank the organizers for presenting me with a title that seems to connect B vitamins and omega-3 fatty acids, which I think gives me an opportunity to talk about something about multi micronutrient and nutrient interactions. And I hope that I can persuade you that some of these interactions may be even more important than concentrating on individual nutrients in a somewhat more reductionist approach. Now, let me start out with this poster child of Alzheimer's disease. This is August D., who is the subject of Alzheimer's 1907 report, in which the pathology of presenile dementia was described, emphasizing a new observation, or somewhat new observation, with the deposition of plaques and tangles in the brain of this woman who was seriously demented. I might say that it's of interest that one of the major manifestations of her dementia was that she was convinced that her husband was cheating on her. Whether that was dementia or an observation about the reality is something for the historians to unravel. The reason that this study is so important, it was so important that along with a couple of other pathologic descriptions, it changed the whole nomenclature of what we talked about when we had previously talked about senile dementia or presenile dementia, which was often talked about as associated with hardening of the arteries. And I think I may try to persuade you that some of that relationship to the vascular system was appropriate. But here's a very recent article that was published by our colleagues from Oxford, which actually reports an actual association between omega-3 fatty acids and B vitamin status in a randomized controlled trial. And in this case, the B vitamin intervention had an effect on the cognitively impaired elderly, and to some extent on atrophy, but it was particularly observed in those people who had a deficiency of long-chain fatty acids in their in their retrospective analysis. And so I think you have here the possibility that there are interactions between nutrients, and I would like to suggest to you that some of those interactions have to do with the vascular system. Now, to give you some idea about the dimensions of this problem, that the growth in the numbers of people with dementia in high-income countries is very high, and it's even higher in low-income countries and is growing more. And as you see, this tsunami of seriously impaired elders presents a problem not only globally but even nationally of enormous proportions. These are updated numbers to show that this is going on worldwide. It's not something just in Western nations. And if one talks in terms of the global societal cost, you can see that in high-income countries and middle-income countries, the cost in billions of dollars is essentially unsustainable. The New York Times yesterday had an article on the front page that talked about the burden of families that are taking care of their elders with cognitive disabilities. So there is then the challenge. I've called it the nutritional imperative. There is the challenge to find ways of within, let's say, the nutrition and related activities, some ways of decreasing the risk and decreasing the trajectory of these important problems. And as you can see, if we could move the slope of these curves from to later onset of symptoms, and if we even so that even the disability was prevented, we could make an enormous impact on public health. So Katie Tucker did such a good job of talking about the factors in elders which influence the requirements for some of these nutrients, that I'll focus my comments on something more on pathogenesis and some of the physiology that we're dealing with here. Now, in this slide, you'll see homocysteine at sort of a key juncture that is influenced by at least 3 of these B vitamins, folic acid, vitamin B6, and vitamin B12, all of which present different kinds of stress in the elders. And I think it's of interest that that homocysteine, whether or not it's involved in the pathogenesis of vascular decline or cognitive decline, it is a very important marker of the status of the interaction of these vitamins. Now, and it is associated with, here's work in the Framingham study showing that in the red line, you have the cumulative incidence of dementia over more than a decade. if your homocysteine levels are in the highest quartile, and a great deal lower rate of onset of incident dementia in the green line if you're in the lower quartiles. And so this is called the kind of evidence that homocysteine is a risk factor. Whether it's a factor directly in the pathogenesis is as a reflection of its integration of B vitamin metabolism continues to be a matter for discussion. But this observation, which comes from the same study that I think Katie Tucker referred to earlier, the so-called NAME study, in which she was involved, shows a very interesting thing, that if you look at the red bars, you see that as we go up in the quintiles of homocysteine, there is a clear decline in cognitive function with higher homocysteine levels. Interestingly, if you look at the blue bars, even over the same range of homocysteine levels, if there's not other evidence of cerebrovascular disease, you don't see that relationship. And I think this is one of the important observations that causes us to be quite interested in the cerebrovascular system as part of the understanding of cognitive decline and loss of brain health. Lipids are obviously going to be important in this because lipids are an important part of the brain. And so turning a bit to the fatty acids, we can think of how important they may be in lipid metabolism in the brain. And I'll call your attention particularly to one of these, phosphatidylcholine, which is another integrator of these metabolites in the sense that phosphatidylcholine has that methyl group, which is also dependent on some of the methylation reactions that Katie Tucker mentioned that are participated in by B vitamins like folate and B12. And here is a similarity that one sees in omega-3 fatty acid deficiency with the so-called white matter hyperintensities in a brain scan around the ventricles. And it's interesting that both levels of fatty acids that are low and high homocysteine levels are associated with similar white matter hyperintensities, which are believed to be associated with small vessel disease and do correlate with cognitive decline. And one of the questions that I think needs to be answered is, since we get most of our fatty acids from shorter chain omega-3 fatty acids like linolenic in the case of omega-3 and linoleic in the case of omega-6, in order to chain elongate and desaturate to levels of the DHA that are needed for incorporation into the phospholipids in brain, we have to go through a number of steps. We don't have good information yet about whether older persons have a poorer efficiency of this chain elongation and desaturation. There is some evidence, but it's not solid. And this is going to be something of significant importance as we look at the interaction with the fatty acids and brain health. And then just to remind you that these phospholipids in the red bars are very important parts of important membranes in the brain, and including the myelin sheath that surrounds the neurons and the neurons themselves. And I think we're going to be seeing more and more about what is the specific relationship between brain lipids that have incorporated these large amounts of DHA, the long chain form of the omega-3s, and the maintenance of brain health. Now, before commenting on this, which I picked partly because it was an AARP funded study, but let me not make you try to figure that slide out while I'm making a couple of other preliminary remarks. There have been, so the question is, what has been done to look at the ability of B vitamins or omega-3 fatty acids and intervention studies to affect the trajectory of cognitive loss, of loss of brain volume, of loss of specific focuses of memory. And here I think there's a very interesting set of observations that are coming along in which the message is, let's not be too reductionist. Let's recognize that there may be different factors that are interacting that may result in a positive effect. And so you have the finger study that some of you will know about from Finland, showing that if you use multiple nutrients that are involved in a diet that is focused on the vascular system, but you use a multimodal intervention, which includes such things as exercise and other environmental things, you get a much clearer beneficial effect. And this again, focus on the vascular system. Bruno Velas' study in France similarly showed that multimodal interventions had a greater effect than any of the individual interventions in some large studies. And I think that's a message which I think we're going to be dealing with a lot in the coming period. And here's just to pick up on, to pick up on a point which I think Katie Tucker also introduced. And that is the idea that dose, whether we're dealing with intervention studies, or maybe even whether we're dealing with the way in which diet meets our requirements, is important. And there's not a unit, there's not a simple dose response that more is better with a given nutrient. This happens to be a folate and colorectal study, which AARP, and I think what you see is that as deficiency of folate is less, that is to say, as the folate intake is better, you see a decline in these in the onset of colorectal cancer, but then you start to see a change in the curve as you get to higher levels. We didn't see whether in this population there actually was an increase that the curve is actually U-shaped, but in fact, there's a lot of evidence in the case of brain health, that there may be an U-shaped curve where low folate status can be may be helpful in decreasing the onset of disease, of the brain disease, and so forth. That there may be an inflection point at some higher folate intake, and that even at high levels, you may actually have an adverse effect. This is particularly important in a population such as the elderly that has a fairly high prevalence of vitamin B12 deficiency, where we're putting a lot of folic acid into the food supply, into flour. This is folic acid. This is not natural folate. And we don't know, as Katie said, we don't know yet what the implications of that difference are. And so I think the idea of thinking about dose and interventions, thinking about the possibility of that kind of dose response effect is something that we're going to be considering much more as we talk about interventions and not only their benefits but their safety.